I welcome you all to this fresh new episode of Trailblazers, Charting Paths, Inspiring Destinies. In the bustling corridors of public health, where data meets empathy and policy intersects with human lives, there exists a remarkable figure, Dr. Armida Fernandez. Her journey is not merely a resume of accomplishments, it's a symphony of compassion, resilience, and unwavering commitment. Dr. Armida Fernandez was born to a Goan family in a small town in the state of Karnataka. Her father was professor of English literature and fought for the Indian independence. Dr. Armida had a deep passion for protecting children from an early age, which drove her to become a pediatrician. She spent most of her working life in Sion, one of the Mumbai's largest municipal hospitals. The disturbingly high rates of infant deaths among the poorer patients led her to study neonatology, a virtually unknown field at that point of time, and realizing the potential of this field to save young lives, she launched a department of neonatology way back in 1977 in her hospital. Simultaneously, she introduced a series of low-cost strategies in her ward for the survival of babies. Her next major initiative focused on breastfeeding, and she set up Asia's first human milk bank in 1989, emphasizing the importance of breast milk for premature and sick infants, while relentlessly campaigning to popularize breastfeeding and expose the harmful effects of formula. In fact, we are grateful, and she was the guiding force when we at Fernandez were setting up our first human milk bank in 2007. Dr. Armida is also the founder trustee of SNEHA, which stands for Society for Nutrition, Education and Health Action. SNEHA is an NGO working tirelessly on health, nutrition, and violence against women and children in vulnerable urban slums. The other initiative of SNEHA is palliative care, which is supporting patients and families suffering from life-limiting illnesses through outpatient department services and home-based care. She has been the professor and head of neonatology at Lokmanya Tilak Municipal General Hospital for over 25 years and also the dean for 3 years. Throughout her life, she has been dedicated to service in public health, and her work continues to inspire and transform lives. In summary, she is a visionary, achiever, innovator, explorer, influencer, trendsetter, change maker, and most importantly, a wonderful human being. Thank you, Dr. Armida, for accepting our invitation. Today, she talks to us on Adapt, Unlearn, and Innovate, and shares her journey in healthcare.
Thank you so much for this introduction. Sometimes when people introduce me, I sometimes wonder if you're talking about me or someone else. They're such wonderful words. But as I was talking that, you're the change maker herself who started this series, should be first interviewed. And I'm here, in a way to talk about what I have done in my life. I was very fortunate as a doctor to have been the ability to work in different sectors. You've already heard about my work that I started in Sion Hospital. I was very fortunate to be in Sion Hospital. It was not only a large municipal hospital, but it was the poorest, the sickest and the most desperate people who came to our hospital. And there were about 8 to 10,000 deliveries and sick newborns brought to our hospital. I also worked in a private sector, fully family for 4 years. And then for the last 25 years, I worked in SNEHA. So let's start with, all of us in life. I'm sure all of you, like as I have faced challenges in life. They could have been personal challenges, and they could have been challenges in our place of work, families or place of work. And when we face these challenges, we have to have mechanisms to deal with these challenges. And the mechanisms that I have, some of the mechanisms that I've used to deal with them is to really adapt, unlearn, and innovate. And let me share some of these challenges with you and how I overcame them. Let's start with the first. I was in the 70s. I was a senior registrar, joined as senior registrar in Sion Hospital. I'm giving you my age, quite happily. But there I was a senior registrar, all keen to work with patients, to do research, write papers, read papers. So in the 70s, there was in Srinagar, they were having a conference, and I went to the head of my department. I said, sir, I want to, I want to read a paper, but there is no time to do any research. So he said, why don't you do some, look at the data that we already have, analyze the data, and then you can read about it. So very happily, I said, let me look at the data of neonatal deaths in our unit for the last 5 years, and then I'll analyze it and read it. Right enough. Here I was in Srinagar reading my paper on neonatal deaths in Sion Hospital, and believe it or not, I was the laughing stock of that conference. I know, unfortunately, they didn't have tomatoes or eggs. But, when I came down from the stage, the senior pediatrician, my head of the department wasn't there, said, how could you read a paper like this? What high mortality in your hospital? You shouldn't do that. Came back, with so upset. And I went to my head of the department when I returned. I said, Pastor, why did you allow me to read this paper? They laughed at me. And he asked me one question. He said, is that the truth? I said, of course it's the truth. I've analyzed the data meticulously, found out the causes of death. And he looked at me and he said, why don't you do something about it? And believe it or not, in that single split of a second, I would say, I was converted from a pediatrician into a neonatologist. And no degrees, no clinical experience. Newborns were being looked after by obstetricians, the normal ones, and all the pediatricians. I said, I am going to try and find out why babies die and what I can do about it. And therefore, there was just that one thought. And I think I should add this to my title, because my head of the department said, you need to accept the truth. So before you adapt, you need to accept the truth. And that's what I did. And then I tried to analyze what are the causes of death that had got them. The commonest cause of death was sepsis. Trying to find out, why did our babies die of sepsis? And we first said that, yes, they could have been breathless. There was those who were resuscitated, and they had some breathlessness, they had pneumonia, sepsis, and died. We understood. Then we had babies who developed diarrhea in the unit. They had diarrhea, developed sepsis, and they died. And a third set of babies, actually, the moment we put them in the incubators that were there, within 24 hours, they were septic without being breathless, without having gastroenteritis. So then I sent cultures from those incubators, and what do you think we found? That we grew Pseudomonas strepsila from those incubators. Those incubators were actually thriving grounds for these organisms that cause sepsis in our preterm babies. And my first thought is, how do we clean it? There was no way. I don't know if you all remember, those incubators were given to us by UNICEF. I used to call them prehistoric, metal ones, and there was a side water bath for humidification. And that water was difficult to change. It was difficult to clean. There had no nurses. We didn't have enough staff to clean. And I said, what am I going to do with it? I said, we must change those incubators. Go to the hospital at the administrative side. They said, we have no money. Remember, municipal corporations never have, governments don't have money. In those days, especially, no money at all. We couldn't buy, so the only thought is, if I have to save my babies, I have to get rid of those incubators. And therefore, we got rid of the incubators. And then what? How do we keep our babies warm? And therefore, we have to think hard. When we talk of innovation, I'm not talking of big innovation. How would I keep my babies warm? We had a small room where we kept our preterms, and we had heaters in the room. Heaters kept the bigger babies warm, the smaller didn't get warm. So we used lamps, 40 watts, 60 watts, 80 watts to keep the babies warm. Water from the skin, there's epidermal water loss. And when the water evaporates, these babies lose heat. We applied oil on the skin of the baby. All this looks, is this science? But you know what I did? It was a medical college. We had students. Whatever we did, one postgraduate, instead of having those thesis, I'm sure PGs today will laugh. Our thesis was keeping the temperature of our babies warm with lamps, with the application oil. All our students were working on these theses. And what do you know? The babies kept warm without incubators. What was the other causes of infection? There were wash basin that we have to wash hands after seeing every baby. The wash basin was outside the unit. All I had to do is take it inside the unit. So simple. There was one grey towel hanging there through the day. Must have been teeming with all sorts of organisms. We had to get rid of that. How do we dry our hands? And I'm talking about late 70s, early 80s. I had seen in Taj that there was a hand dryer, to dry your hands. And I got someone to donate it. So we got rid of towels and then we dried our hands under the warm. I used to say, what's the similarity between in Taj and Sion Hospital? We had warmers to dry our hands. So we had that. What was the other cause of infection? The other cause of infection really was we used formula milk when formula milk was not available, like in many of our hospitals, we used animal milk. We used bottles to feed the baby. And then we had to say that if we have to stop this infection, we need to get rid of our bottles, get rid of the formula, get rid of the animal milk, and give all babies breast milk. And that's exactly what we did. And remember, we're talking about not few babies. Total number of babies were sometimes 8 to 10,000, sometimes even. So we got rid of this. We got mothers to come in and feed their babies, express their milk, and whatever was excess was kept in the fridge and then given to the babies. And there was another thing. We didn't have nurses. We couldn't increase the number of nurses in the ward. And said, how will we get nurses for all our babies? And I said, we will get one nurse for every baby. I changed the rules. No entry. I took off the no entry sign from outside the prenatal unit. I said, all mothers will come into that prenatal unit. Maybe today everybody does that, but at that time, in the 70s, that there was no entry. So got every mother coming to the unit, and she was a nurse to her baby. What did she do? She cleansed her baby. She fed the baby. She put the baby to the breast. You know what? Even if they were small, 32, 34 weeks that were stable, I said put them to the breast. Today, we use the term, lots of research on non-nutritive sucking. The words I use, when a baby is, you have to teach them early, tutor them to suck. Earlier, when you teach them, they start sucking earlier. So we put babies to breast, we spoon-fed them, and therefore every baby that was there was getting human milk. But it was not really scientific. Sometimes most often the mother gave her milk. If the mother was not available, another mother's milk was given to that baby. It was really not scientific. We didn't know the level of hygiene that was being followed. We were storing it in the fridge itself. And then I realized that if we had to really bring about change and make sure that every baby has access to human milk that is safe, sterile, then we have to start the human milk bank. And the challenge to start a human milk bank was not easy. I think at every stage it was not easy. Even when I said stop formula and bottles, it was a real challenge to convince people. But I had my head of the department who said, save lives, was backing me. To start a human milk bank, some of the people in administration, at the head office thought that it was not okay in my head to start a human milk bank. But I realized that is the way to take it ahead. What was the challenge? One is, will the municipal corporation pay for a human milk bank? Of course not. They would not give me an incubator where some human milk bank that never existed. What the challenge is, where do you get money? And I learned very early in my life that there are many, if you need money, go ahead and ask, and you will get many donors to help you. And that's how we got a donor for the human milk. Also want to share the story. Many people, even in the hospitals around this, I thought I was not doing the right thing. But to convince the administration to give me staff, to give me a technician, to give me a nurse and all was next to impossible. And when I went there and I told the people, non-medical people sitting in those chairs to give staff, they said, Madam, what are you doing? Giving one mother's milk to another baby? And I made a similar sort of gesture. I said, Sir, but what are we doing? We're giving milk from one human, mammal, another animal to a human baby. And I think that irritated him even more. But then, fortunately for me, I reminded him that even Lord Krishna was wet nursed. And therefore, you can definitely give human milk to another baby. It's a long story, but these challenges were overcome one by one. And in 1989, of course, we started the first human milk bank. And it took decades, I think, to convince the rest of the country to start human milk banks. And then we did a lot of scientific evidence to show how useful human milk is for preterm babies and sick babies. So those were the challenges. There were simple things. There were many others, a list of many things that we did to reduce mortality in babies. And these were low-cost mechanisms to save babies' lives. I'm not talking the human milk bank. That itself wasn't too expensive in those days, but I'm talking about breastfeeding, hand washing, having a basin, ensuring you don't use towels to wipe your hands, getting mothers to feed. These were low-cost mechanisms. So there, in my mind, there was another challenge. He said, if we in Sion Hospital, such a large hospital, can bring down mortality with simple methods, it is our mountain duty to spread the message to other hospitals. So remember, our municipal corporation had 13 peripheral hospitals, 26 maternity homes. It's a huge, and these babies were dying in their hospitals, or when they were very sick, they were being actually transferred to Sion Hospital. I said, we have to spread the word and teach them. And what was the challenge? How do we teach them? Went to the BMC, the people in charge, and I said, we want to do this training program. There is one sentence you must remember when you are dealing with the government. Sentences, it will not cost you any money. Once you say that, they're not worried. You said, go ahead, you can train as much as you want. And that's exactly what we did. And in those days, of course, we didn't have all the projectors that we had. With a small projector we used to carry in our hands, round projectors. We didn't know how to travel. We took trains, we went to hospital. The poor staff of the department must have cursed me, but we went to spread how to save newborn babies in municipal hospitals. Another challenge, but this is how does one overcome this? Because we were exclusively breastfeeding in 1989, when 91, 92, the Baby Friendly Initiative was started by UNICEF and WHO, and they wanted to spread that. And when we learned that our hospital was in many ways already baby friendly, all babies were getting human milk, they came and approached us and said, can you do this baby friendly hospital across the city, across the state? Of course, we said, that's exactly what we want to do. We did it neonatology once. And the difference is, believe me, when you have funds, then you can plan, you can, organize, and you can do an excellent training program. So this is another message. If you want to do a good job, then you have to have the funding for it. And once UNICEF gave us funding in a very organized manner, I had a training manual for breastfeeding for trainers. It's a blue book, the first book for it written by for the country that we had. And we had a video that goes with that training manual. So we use the video. Second is that when you want to train and you want to do it in a large scale, you can't do it alone. And the challenge is, how do I do it? And how do you do it is you get everybody on board. And therefore, we had not only neonatologists, pediatricians, obstetricians, people from the community medicine, the nursing, the dietitians, all come together. And because it was at the city level, where the Bombay IAP, the hockey, or the obstetricians, they were all on board. And we did an excellent training program where we, most of the hospitals, not only the private sector, public sector, but also baby trained. Once that was over, I said, can we take it at the state level? So I have to add two things. When you want to convince people, this is the learning that I've had, you need to have data. So even before I went to the administration in the municipal corporation, we did a baseline study of breastfeeding in all the municipal hospitals. And although they started breastfeeding at birth, first follow-up, second follow-up, third follow-up, when they came for the second immunization, over 30% of babies they had added top milk, they had added bottles, they had also got diarrheas. It was a simple study, nothing to be published, but we had that data in hand. So when we went to the government, I had to meet the director of health services, and he must hear this. When I went to him, it was a very dynamic man, and he said, sir, we want to train people across hospitals, across the state. I said, madam, are not all mothers in India breastfeed? He said, sir, they start, especially in the low socioeconomic class. That's what I was talking about. I said, but see, this is the data we have in the city of Mumbai. 30% have started top feeds by the time the baby is 6 weeks, 2 months. I said, really? He said, okay, let's do one thing. I'm having a meeting with all the civil surgeons in the state. Come and attend them and talk and tell them about it. And I told them, and at the end of the meeting, do you know what he said? He said, I want a bottle breaking ceremony, and please take photographs and send it to me. So if you have one person to back you, and you have data to show him so that they can check, it makes all the difference. We had a PR for the state. We trained people across the districts, training of trainers across the district. And there was a time when Maharashtra that year, Maharashtra had the maximum baby-friendly hospitals in the country, the state to have. Of course, you can never beat it. In the next year, of course, Kerala and all had outdone us. Practically, I think every hospital there in the state was baby-friendly. But the challenge is how can we train? How can we get together? How do we work as a team? How to convince people? That's how we are well ahead. The next from here, we found that our mortality rates, as while the training was going on, the mortality rates, which was more than 50%, had started dropping and dropping quite a lot. It was coming almost to 10%. And then we said we need a good follow-up. So we had a high-risk follow-up, and we were following up these babies on the OPD. And while we sat in the OPD to follow up this baby, found that many of the 600 grammar to 700 grammar babies didn't come back. And I sent word, and we sent the residents to find out part of someone's thesis, what happened to these babies? Many of these babies, after staying weeks in the neonatal intensive care, and we struggling with them, and the mother staying there in the hospital with them, those babies went home and finally died. Some of the babies who came to the high risk had complications, cerebral palsy, some had ROP because were really preterm babies. And then I asked myself, what exactly are we trying to do? We are dealing with people from the slums. All our patients were really poor, vulnerable, coming from the slums. And we keep them in hospitals, they go home, finally lose their babies. Not only that, they're going to spend their life looking after cerebral palsy, looking after a child that is blind. Are we really doing a service to these mothers? And the more I thought of it, I said, the hospitals do something. We have a service saving, but if we really want to save newborn lives, working in the hospitals alone, we need to move out of the hospital and move into the locality where these mothers stay, get into their communities, get into their homes, to try and get them to get the mothers to be healthy, eat well, go for antenatal clinics, high risk signs, go to the hospital in time so that they can have a normal delivery and chances that their baby will and survive. And fortunately, when you have these thoughts and these thoughts keep bugging you, and the donor said, small donation, he said, you want to work in the slums, here with the money, you can start working in that. That's what exactly I did. And then Sneha was born. Because Sneha stands like, Society for Nutrition, Education and Health Action for Women and Children. And we work on maternal. We started working in maternal newborn health, and we also worked on violence against women. And the reason being that during one of our perinatal meetings, a 6-week baby was raped, brought and died. And you know that as when we sit there and we discuss, we see who was that animal and what finally happened to him. And working in hospitals and institutions, we don't have a chance to follow up. In a country like us, we don't know finally who it was and what happened and was he ever convicted. But at that time, I swore to God, I said, I don't know what happened to that baby, but when I retire, I'll work on this issue. And therefore, in maternal newborn health, we added violence against women. So I moved from this air-conditioned room of the dean into the slums. It's across the wall, slums of the Rani. And there I said, adjust and unlearn are the two words you have to use when you move from one thing to another. First of all, we use as professors to teach students, and we are taking notes and writing down, wanting to learn. They have exams to prepare for. At the day you give orders and people want to do what you think they should be doing or help them do what they want to do. And here we go, the slums are mothers want to learn. We're not stone mistakes. We have to change behavior. And to change behavior, we have to go into the homes, to sit on the floor with them and talk to them. And we have talked to them and actually find out what they do and why they do what they do. And then we have to try and change their behavior. And changing behavior, I must confess, it is not a question of hours or days or lectures. It's a long, and you have to use different methods. We use many methods, continue. One of the methods which I used in hospitals and was AI, but no time to talk about it. But we use these methods to change behavior. But what we understood while working, lessons that we learned while working with Sneha, the thought is I want to save newborns and therefore I'm going to look at newborns. Because I want to save newborns, I say mothers should be healthy. Finally, we realize if mothers have to be healthy, then the adolescent girl has to be healthy. And if she has to be healthy, the child has to be well-nourished and healthy. And if so, finally, it has to be a life cycle. So starting with maternal newborn, then we went through the life cycle, and now we cover the entire life cycle. Second thing we learned that we put the burden on the women. We want the women to change. You can do this. You can change the world. But then finally, we realized that you have to involve men, and that's another lesson, important lesson, if you want. So today we have men's groups. Believe it or not, adolescent boys and girls, of course, because they have to know about nutrition, they have to know about maternal health, they have to know about violence. But we have men's groups for prevention of violence against women, and that has made a lot of. So one lesson. The second thing when you work and you want to bring about change in health, you can't do it only in the communities, and can't do it only in hospitals. So you have to work with the communities, work with the system, and you as an NGO are a catalyst trying to bring the two together. So you work to bring the two together. So while we work with communities to change behavior, we work with the municipal health systems to improve the quality of care. And then we started for the first time in the system a referral system. I told you there were 13 peripheral hospitals, 26 maternity homes, 150 health posts that were not being used at all. They were using it for immunization. So we started a system of referral across the city, make sure that the right mother, the right baby goes to the right center, high risk, where they go. So this was done, and we worked with doctors and nurses. We worked with when we work, for example, with child nutrition, we work with the ICDS. We partnered with the ICDS. Violence against women, we partnered with the police and with the free legal aid system. And the reason why you do that, because NGOs can't last forever. When you work with existing systems, you create a sustainability in the government finally takes over. And we're trying to back out, especially in our nutrition programs. The third lesson we learned is that if you are doing this work, you have to have it research based. And unless you have good research, there's no way you can convince the rest of the world and convince change policy. And therefore, all our work in SNEHA is researched, based with monitoring and research. Today, of course, we know that unless we have technology, we cannot, and therefore, technological advances, every health worker that we have has a phone, enters all our data on the phone, and we put it to so that we have data online all the time coming in and being fed back. So that is technology. And the last is that although we have 500 people working in our NGOs, we have 7,000 volunteers from the slums that do such a good job. And therefore, we have to take them all together to bring about that change. And SNEHA has done a great job. For example, we cover over 1 million people today, 25 years, of course, 1 million people. We've been able to, from started, I told you, in a few hospitals. Now we are across from one slum. We are now in 7 cities. We started with few hospitals with the referral system. Now we are more than 151 health centers from the health post onwards. We cover all of them in 7 municipal corporations across Greater Mumbai. We've been able to bring down child wasting and stunting in a large program in the slums of our city, and over 1 lakh people who have addressed violence. So SNEHA has been able to do all that, and working in the social sector makes a lot of difference to the communities that. And finally, I want to talk about a personal, we come across personal challenges. And how do you respond to a personal challenge? About 11 years ago, I lost my only child to cancer. She was in her 30s, she was young. But the worst thing is, she got the best of treatment. We were both doctors. But she suffered. She suffered throughout. And then it was a painful way we lost her. And we suffered with her. Being our only child, both of us suffered. And after we lost her, I kept thinking, what is it we could have done to have decreased that suffering? My husband never recovered from it, actually. What we have done? And then I realized there's something like palliative care. We had it at Tata, there's an MD degree. And believe it or not, so caught up in what I was doing with mothers, babies, social care, I had not heard of palliative care. I'd heard of hospice because we had a hospice. I thought end of life, that's where we keep patients. Then I realized that we can address the suffering of people, not only physical, but the mental suffering, the social suffering, and also counseling not only the patient, but the caregivers. And that's when, in response to that, I started the Romla Palliative Care Center. And now it is almost 7 years, and we've reached out to over 2,000 patients. We look after not only cancer, palliative care is all life-limiting disease, and therefore looking at all life-limiting disease, where we have a center where patients come, but we have teams that go to the houses of these patients and deal with them. Also, having training courses for pediatric palliative care through IAP. And therefore, I say the challenge, personal challenge, what you suffer, and how we can act. That action is not really for people around. Yes, it helps the patients, but it helps you personally. So I think I should change my title. It's not just adapt to the situation or relearn when you're working in slums what you could do, how to do, or get rid of incubators. Innovate when you need with technologies that save lives that we did, like heaters or the human milk bank. But finally, act so that act makes converts what you feel into action and makes a difference. I don't know how long I've been talking, but before I end, I want to end with two things. One is that, I'm here giving this talk and I'm taking the credit, but it's not true. You can't do it alone. I could do what I did because I had a wonderful team with me. My team in Sion Hospital, my team of staff that worked with me in the human milk bank, wonderful staff in my NGO and the palliative, and they are the ones who do the work. Who gets the credit is me. That's really unfortunate. So the credit goes really to the entire team. The second is really, I was just telling Avita that we cannot take credit for what we've done. And why can't we take credit for what we've done? Because I'm a believer. I believe that God works through each one of us and that you just have to listen to it. And how do you listen? You open your eyes and see things around it. You open your heart and feel for patients. And therefore, God works through us and does. And therefore, we cannot take the credit. It's not about who does the work. And thank you so much for having me.
Very inspiring journey and the talk. And I think it's a symphony of wisdom, compassion, and innovation. I don't know why you said you were hesitant about the age, but I think all of us are far anywhere close to what you have been doing, because I think whenever you saw a problem, you tried to solve it, and it was basically, the stories that you wove together, the healing, resilience, hope. You reminded us that public health isn't just about data; it's about hearts beating in unison. Thank you for being a guiding light for the generations to come. Your legacy will lives on because you don't know how many lives you are touching. Just a small example, the milk bank that you helped us set up way back in 2007 has led a Nilofer, the government hospital here, the public sector hospital, to start the human milk bank. And then sort of once Nilofer started it, literally quite a number of hospitals have started. I hope someday NNF will come up with recommendations that all neonatal units, at least the level 3 units, should have a human milk bank. Because, I mean, we are seeing the sort of the, as data says and shows what is the difference that it's making. I think we need to make a appeal to the NNF, at least for the level 3 units to be accredited to have a human milk bank as a mandatory thing. Our deep admiration and deep gratitude to all that you do, ma'am. Thank you very much.